gracias a todos por estar aquí a la hora postprandial después de un suplemento nutricional que hemos tenido hace un minuto, y les prometo un suplemento científico con esta charla magistral. È un onore e un privilegio per la SEA di riceverla al nostro congresso annuale. Mi dispiace, ma la mia conoscenza dell'italiano è limitata. In realtà non parlo italiano, por tanto continuaré en castellano e inglese. Es un placer para nosotros recibir aquí al profesor Catapano. Sin duda es uno de los puntos fuertes de nuestro congreso. Gracias a Rosa por la gestión y por darme el privilegio de estar en esta mesa recibiendo a Alberico Catapano. Si me pasan la presentación, haremos una minúscula presentación biográfica de Alberico, aunque los más seniors de la SEA sin duda conocen su trayectoria, y podemos directamente pasar al núcleo fundamental de la presentación. Alberico Catapano, siguiente diapositiva, por favor. Como la mayor parte conocéis, Alberico Catapano se especializó en farmacología clínica en la Universidad de Milán, donde ha desarrollado prácticamente el núcleo fundamental de su trayectoria científica. Es catedrático de farmacología en la Universidad de Milán, es director del Centro de Epidemiología y Farmacología Preventiva, CEFAP, del Laboratorio de Lipoproteínas e Inmunidad de Aterosclerosis y del Centro para Estudio de la Aterosclerosis en el Hospital de Bassini. Aquí, precisamente, nos es especialmente importante resaltar su papel como presidente de la Sociedad Europea de Aterosclerosis entre los años 2013 y 2016 y su liderazgo en el impulso de distintas guías y consensos europeos fundamentalmente dirigido a las dislipemias. En concreto, fue el coordinador de las guías de 2011, la persona encargada, el chairperson del 2019, y ha contribuido como senior collaborator en el update del 2025. Y quizá también es importante destacar, aparte del liderazgo en la conjunción de distintas guías terapéuticas, el liderazgo en que trabajemos juntos desde distintos ámbitos de distintas unidades. En particular, ha tenido un papel crucial, protagonista, en la puesta en marcha de la Lipid Clinic Network europea, así como los registros de hipercolesterolemia familiar homocigota y heterocigota internacionales. Sus publicaciones superan el millar, más de 60.000 veces citado, con un índice H superior a 100 y con papers en el New England, Lancet, European Heart Journal, Atherosclerosis, Circulation, etc. Obviamente no vamos a detallar aquí, sino centrarnos fundamentalmente, como se ha referido también a lo largo de esta mañana, en su aportación fundamental para los que, aparte de la charla de hoy, quieran recrearse en este concepto con más tranquilidad. Hace poquito, el año pasado, publicó en Nature Reviews in Cardiology, junto con Eugene Brownwell, como todos conocéis, el líder mundial de la cardiología, editor de la parte cardiológica del del Harrison of Internal Medicine, así como del libro de referencia mundial de la cardiología, en colaboración también con Brian Ferns, que ha sido una de las personas que en Europa más ha contribuido a incorporar el concepto del tiempo y de la evaluación cuantitativa de la exposición al colesterol como fuente aterogénica. Y sin más, termino mi introducción. Vamos a disfrutar todos la presencia de Alberico Catapano en nuestra... It is your time, Alberico, for your lecture. Thank you very much.
Thank you for the very kind and probably overstated introduction. So this afternoon, I'll try to somehow recapitulate for you the concept of cumulative exposure to LDL in the frame of a risk evaluation. Here's my disclosure with possible conflict of interest. As a matter of fact, what we will discuss today has nothing to do with drugs in a real specific thing. Now, all of you know that cardiovascular diseases are the leading cause of death and also of inability. The fact that deaths adjusted per age have decreased is perfect, but that's just reflects the fact that we are living longer. Sooner or later we will have to die, sooner or later we will get sick, and still cardiovascular diseases account for more than 32 to 34% of total mortality, in Europe, 28% is due to cancer, and then there are other causes that one way or another can be, some of them at least, reconciled with cardiovascular events. Now, up to a few years ago, we have always had this story of conventional risk factors, age, sex, ethnicity, and family history, which are by definition non-modifiable. Genetics were listed among them. We have learned, and we are learning in the last 10 years, more or less, that we can also modify genetics. So somehow this story of genetic being a non-modifiable risk factor for cardiovascular disease is not completely true. That's not only true with lipids, it's true with other major diseases in the cardiovascular area, like amyloidosis and others. And the modifiable classical one are reported there, and it will suffice to say that the usual suspects are listed there. Let's go to the LDL. LDL is causal. This is not something that is coming out, from the blue, but is really that, because it is fulfilling all the rules for causality that we know and we ask for, including the demonstration that there's not only a temporal relation, like in epidemiology, high LDL, high risk of cardiovascular events, but also the reverse. If you decrease it, as a consequence, you decrease the events. And these Hill criteria are fulfilled, all of them. And the evidence, as I said, comes from epidemiology, from genetics and genomics, from pathology, and for intervention trials. Now, how LDL can be causal in the disease? Biology has helped us in understanding that, and there are a lot of mechanisms that have been put forward, but will suffice to say that LDL do have the size that will allow them to enter the subendothelium, and by having ApoB on their surface, able to interact with the extracellular matrix there. Because the key point is not only having LDL getting there, but is also sticking, allow me to use that word, in that point. But once there, a number of modifications can occur that allow the LDL to become more heterogenic and stimulate a number of responses, including innate immunity, and then get inflammation at a local area there, and development of plaques that are always linked to the burden of cholesterol. The role of LDL goes throughout the beginning until the end, where we have the plaques that are fissuring, plaques that are unstable because of the accumulation of lipids at that level. But let's make a step back and look how the cholesterol was related to cardiovascular disease. This is a potpourri, if you will, of different projects that started a long time ago. And all of them have consistently shown this correlation between cholesterol at that time, not only LDL, just cholesterol, and cardiovascular disease. When you look at cholesterol, in the vast majority of the case, if it's high cholesterol, it's high LDL. There are a few exceptions, it's true, but in general, if you look at the population, you don't make much of a mistake if you say high cholesterol, high LDL. The other important point I want you to look with me, and that should make us to suspect something, are relatively old data that show the relationship between levels of cholesterol that you see over there. If I can, okay, over here, you see the levels of LDL cholesterol and the rate of cardiovascular events, splitted by age, 10 years. Obviously, you will say there is more than an 8-fold increase for younger people. And obviously, you will say there is 2-fold increase in elderly. However, look at the absolute number. Here you go from 0.8 to 8, 8-fold increase, but is 7, the absolute number. Here you go from 120 up to 250. So the number is much higher. Just to say that the level of LDL plays a role throughout, but also seems even to be more important as you grow older. Obviously, if you look in relative numbers, you tend to say, okay, the relative risk reduction by reducing LDL will be much better in younger than in elderly. But the actual numbers have to change. The other important thing is the genetic. This is one of the first papers that Brian Ferencz published more than 10 years ago. I guess it was in 2012, in JACC, indicating essentially one point. If you take, now we call them variants, polymorphisms at that time, in different genes that have effect on LDL cholesterol, and you see here the effect of the different genes, so orthidine, PCSK9, LDL receptor, you name it. And then you look at the effect, again, by looking at the risk in the given population carried by this difference, you see exactly mirroring what you have. So also the genetics are telling us the LDL is directly related to what you see in terms of events. But that's not the only point. The other interesting point is this one, which we published in 2015. I think it was JACC. You can see here, if you take everything to 10 milligrams per deciliter of LDL, the role of each variant is the same. In other words, if you extrapolate that and you look for variants on Niemann-Pick C1-like 1, which is the target for ezetimibe, if you look at variants on HBG-CoA reductase, which is the target for the statins, and so on, the LDL receptor indirectly is the target for the statins, everything works in terms of the reduction of LDL. And by extrapolation, you can say the benefit comes from the reduction of LDL, not the pathway you are targeting or is affected. And that's another important point when we discuss about new drugs or drugs that are repeating pathways and so on. As a matter of fact, other questions have been raised over time. We decrease the LDL, do we change the lesions? Well, what has happened, I'm sorry, I need to go back, sorry. What has happened here is something that set the stage for the guidelines. There is a sort of threshold around 80 milligram per deciliter of LDL cholesterol where plaque do not go further, but do not really decrease. If you go lower, it appears as if that happens. The other important point is, but if we go low, we have issues in terms of safety. Well, in terms of reduction of events, there is no doubt you continuously get a benefit. Obviously, the absolute benefit depends on how much you have reduced the LDL. But if you go lower, you get a larger benefit. And trials recently have supported this concept. As you can see here, in the Improve It, the old trial nowadays, there was a number of people with less than 50 milligram per deciliter at that time of LDL, 37%. In the evolocumab Fourier study or the Odyssey outcomes, there were a large number of people who had an LDL cholesterol below 40. And as a matter of fact, in these studies, there was no evidence whatsoever that the level of LDL that was reached was linked to any increase of adverse events. In other words, there was no difference whether you end up at 20 milligram per deciliter or 40 or 60. And that's better recapitulated here overall in the Fourier trial. If you look at the two populations in the sense of the placebo, the blue one, and the treated with the PCSK9 inhibitor, the red one, and you have on the right-hand panel there the relationship with the cardiovascular events, you see a continuum there. And there is no price to pay, as demonstrated in this study, in terms of adverse events. Now, In all this system, what we have learned also from the genetics. This graph that you see here is a graph that has been used over and over recently just to demonstrate the trajectory of disease. The graph is somehow adapted from something that Jay Orton published more than 25 years ago. And that was entirely hypothetical at that time from Jay, that suggested that what matters is not only the level of cholesterol you have, but how long you have been exposed. Why Jay came up with that? I don't know how many of you remember the original paper on the Dallas Heart Study that was published by Helen Hobbs in 2006 or 2008. In that paper, she was able to isolate people with variants of PCSK9 who were which were loss of function. In other words, loss of activity of PCSK9, mimicking somehow the inhibition by drugs. These people had an LDL cholesterol lower than of 27 milligram per deciliter as an average, which is not a huge decrease, yet lifelong. And the reduction of events was 80% in this population. Obviously, the uncertainty on the point estimate, given the relatively low number of people carrying the variants, was relatively large. It could have been 60. Nevertheless, much more than what you would have expected, according to what we know from the clinical trials, where we say 1 millimole reduction, 23% reduction of cardiovascular events as an approximate estimate. So that should have suggested us there is an accumulative effect. And that's what we, with Jay Orton reported here, suggesting that the trajectory of the disease can be changed, but what you have built up with time is not going to change. So if you start late in somehow intervening, you can change the trajectory, but still this built here, the disease and the risk built here, is not going to disappear. If you start earlier, it's much better. And this is somehow also reproduced by people with FH. Non-carriers, green, the orange, the carriers of ApoB mutations, and red, the carriers of LDL receptor mutation, nowadays variants, functional variants. What happens? The LDL receptor variants are much more severe in terms of LDL cholesterol, and the curves there depict the exposure of higher level to LDL. While the ones carrying the ApoB mutations, as you can see here, have lower level of LDL cholesterol, and then the curve of relationship to events is different and lower than that, but still higher than that of the average population. So in other words, that's how it looks. You can start anytime, obviously, but the later you start, according to this approach, the lower will be the overall benefit, or the more intensive needs to be the intervention. To make this story fit more, this is something we published in 2018-19, again with Brian. We made this comparison. The red line recapitulates randomized clinical trials. The gray, observational studies, and the blue one, Mendelian randomization studies. Here you have the magnitude of exposure to lower LDL cholesterol, and here the proportional reduction of risk for coronary heart disease. What is the difference in this study? Time. For the trials is reported for all of them to 5 years, for the observational to 12, for the Mendelian randomization to 52. And if you have a lower level of 1 millimole per liter, what you see here, 23% with the trials, 33% in observational studies at 12 years, and 53% in Mendelian randomization, indicating that you accumulate the benefit over time. What is the exposure then? This is a graph we have made together with Brian, from the UK Biobank. Because it's dynamic. It's not just a number. You are accumulating exposures that are different across time. And this is the cumulative exposure of LDL changing by age. You can see the LDL levels by age reported from the UK Biobank. And clearly, we females have lower levels before menopause, around that age. As you can see here, the age around 45, 50 here. And then they cross over and somehow have higher level or above this age. And that also tells us the area under the curve, if you look at that in this area as an proxy for the exposure, is different. Changed dramatically, and that might help explaining why females are less exposed to one main cardiovascular risk as the LDL cholesterol, because the area under the curve is different. But they pick up afterwards as compared to men after the menopause age. Cumulative LDL, therefore, is a direct estimate of a number of lipoproteins that are exposing themselves to the artery wall, or the artery wall has been exposed. And then we can try to use that to estimate the size of a burden there. We therefore can aim to track the rate of plaque progression over time, and that may become, more importantly, the therapeutic target, not the specific number, but for how long you have been low. And what is the extent of that global being lower? This is the area under the curve that we tried to get, the cumulative exposure to LDL in plaque years and CAC score. For those of you who are cardiologists, you know the story about saying, well, calcium, the CAC score, the calcium score may be the threshold to decide if a person has a disease. Well, that's not really true. What the calcium score is telling you is what you have in terms of plaques from the in view of the stabilization, the calcification of those plaques have been stabilized, but doesn't tell you the true story. Recapitulates how much you have been exposed, probably, and how long you have been able to stay under those circumstances. But that doesn't really mean that you are not having plaques there. And this occurs at around 150, 170. And this is a typical area of age 40 to 50. So that means it's a good means of evaluating above 40, 50, but not before, because you get essentially something that is close to zero. The other important thing that average age transition from 0 to non-zero is 53 years age in this experiment. An average age at which a calcium score reaches 100, which is usually taken as the threshold, is 67. So it's not something really that tells you what is happening before. It's just recapitulating what has happened, and you are already almost done, if you will, in terms of having plaques in your arteries. What else is the concept of cumulative exposure being somehow under, well, not evaluated properly? Now, and that's also our fault. You remember the CTT meta-analysis, you see it here. It looks as if after 3 years or 4 years, the benefit plateaus. And we all said, okay, after the first year where the benefit from a reduction of cardiovascular events per millimole reduction of LDL is less, and that's been repeated over and over, then stabilizes around 23 to 21%, depending on the endpoints you are looking. But please look at one point, that is this one. The number of subjects that are in the different years, meaning that different trials have been included. This is very powerful meta-analysis because it's individual data, so it's the best possible meta-analysis you can make. Yet, putting together different trials may make a difference. And did not account, in fact, for the change in LDL levels at each year of therapy because of changes that have occurred in the trials, as well as different trials with different lengths. Is this a concept of having differences between the year reflected with other therapies? Yes, it's there and has been shown in the Fourier and PCSK9. So I don't, in the trials with PCSK9, both of Fourier and the authors, the Odyssey and the Spire 2 as well. And this is true as compared with the statin, essentially the same. So if you were to plot this data for the length of treatment, as we did in this paper published in 2017, starting with the concept of cumulative exposure, you can see here the cumulative decrease resulted exactly in line where you should have been after 2 years, after 3 years, after 4 years, because you discount the first year where the benefit is almost halved, if not less. Now, if we look at the trials in a different way and look for them, the ones that lasted 3 years, the ones that lasted 4 years, and the ones that lasted 5 years, then there is no threshold any longer. They continually increase to benefit. What that means again, you are reducing the cumulative exposure and you are gaining benefit. This is an important message both in terms of the value of the therapy, but also in the concept of staying on therapy, not to stop therapy once you have reached whatever. The other important point comes from, as an example, there have been several, starting from a reanalysis of the studies with pravastatin and simvastatin, and also others. But I just wanted to show you one to make an example. This comes from the Fourier, the open label extension of the Fourier trial. The Fourier trial lasted a few years, 2 years and something, but then went into the open label extension, where the people who were in placebo were offered to switch into therapy. Not all of them did. In the end, from the number of people that were in the original trial, almost half were in the open label extension. But please note what happened to the LDL cholesterol. As soon as they entered therapy, the LDL cholesterol dropped exactly to the same level where the population with the treatment and kept the treatment in the trial were. So that's an important point, because if you look at the curves of the events, cardiovascular death, myocardial infarction, or stroke, you can see here, these are the original curves up to here. Then the curve continued to be different and then parallel out. Still, there is a difference there, but the difference is not becoming larger and larger. Why is that? Well, let's look at the data in the way I said. For a period of time, the curves continued to diverge. You see the blue with the red here, even if both of them were at exactly the same level of LDL cholesterol, and then parallel out. And this is both for the primary and the secondary endpoint. It is even more clear here, if you will. And how has that been interpreted by the authors? But we fully agree with that. In the first 2 years, you see the usual benefit at the first year, less, and going up at the second year. Fortunately, the trial was stopped short after 2 plus few months length. But then if you follow in the open label extension, the benefit continued in the study and stayed there. If you look at what happened in difference of LDL cholesterol between arms, here was almost 60 milligram per deciliter, here was nothing. And you can still see that the delta maintained for some time and then dropped. How to interpret that? Well, the lag we know. Once we start, it takes time to get to the benefit. And that's reproduced over and over. But then we have the effect of memory or legacy, whatever you want to name it. And that's important because you see those differences occurring there. And finally, they pile up together. How that can be recapitulated in what we are saying. Now, this is a curve of events taken from the UK Biobank and taken from the publication you mentioned. This is the occurrence threshold for cumulative exposure to LDL. This is what happens, and this is the cumulative exposure with the risk of events. Now, if you look at the risk of events with age and select from this population people with a 50% higher LDL, the red line here, like an FH, more or less. Here is the average. Here is people with 25 less LDL, and this is 50% less. And that is from the point we can observe 30 years of age. You see the dramatic difference in the incidence of events. If you look for longer time, you see much, much more of a difference. Which is the sequence? Which is the consequence of that? Well, if you go for the cumulative LDL exposure, which is reported at the bottom of this graph, and you plot them in people with an average LDL level, and this is what happens. But not to say the LDL is the all important one, because if you have high blood pressure, that's what happens. The curve goes up high. So that doesn't mean only the LDL, but also other risk factors can modify the trajectory. So it's not only to concentrate on LDL, the concept. It has to be the risk. Diabetes, exactly the same story. Now, this is even more conclusive, because if you compare people with a family history or without a family history, you can see immediately how a simple question and what probably has determined the exposure to higher level of different lifestyles and also to genetic influences in lifetime makes the difference. You can see here immediately, and immediately you can see how that exceeds the risk for these people. So there is a correlation with that and the fact that you have been exposed. And that creates an opportunity to personalize prevention. And then let's go back and see what happens if you start therapy. Let's assume you reduce by 36% reduction. These data are taken for people who have an average 36% reduction at different time. And you can see here the trajectories for those people. So if you have this one here at the beginning, this is what happens. But then if you model that at different ages, that's what happens. So the benefit becomes less and less, even when you do a 50% reduction. In other words, the earlier you start, the much, much larger will be the benefit. See the difference here with this and with that. This is also an evidence for cumulative exposure in a randomized clinical trial, if you will. So if you can take time as the increment of follow-up since randomization, so that means birth. Then if you have higher LDL versus lower VLDL comparison, and this is the group, with lower LDL, and this is the group with high LDL, and this is the average population, the remaining. You can see here the delta of a difference. However, if you take the exposure time in terms of LDL cholesterol years exposure in each of these studies, and then you normalize, that's what happens, exactly on the same line, demonstrating that what drives this difference is the exposure, is not the actual, only the one value of LDL. Age versus cumulative exposure. Again, here, remaining lifetime of risk of MACE for the same reduction in events, the concept of starting early, perhaps you don't need to be so aggressive. It might be, well, you will get a large benefit if you start early. And this is what has been demonstrated here. And participants, and this has been mediated in participants with normal PCSK9 function is the red line, and the blue one is the participant with lower LDL due to PCSK9 loss of function. And you can see here the two different curves. And then we have developed a system of AI in order to be able to mimic that and to predict what happens. And that goes exactly over there. And this is exactly the same in people who survived without an event at 55 years. Again, you can see this benefit by a decrease of LDL. So that mimics the trials we usually do, 55 years. And then we can repeat, just to make a long story short, exactly what is happening in the Fourier and the Odyssey outcome. So therefore, to make a long story short, it is important that you have in your consideration not only the LDL, not only the cumulative exposure, but also the cumulative exposure to other risk factors that collaborate. In other words, if you don't have diabetes and you have diabetes, if you have low blood pressure or high blood pressure. And again, if you take, as I showed you before, everything to the cumulative exposure of these factors, you get exactly the same line you would have expected. So where we stand now with the concept of risk, because that has to do with the risk, just to make it clear. The higher the exposure, the higher the risk. This is a graph of what has happened. Spain is safe, is green. Italy, a bit less, but some countries are much, much worse. And the way we approach risk is this one, and it's completely wrong, because we have an estimate at 10 years, which is the contrary of the cumulative exposure. It's just telling you the results of the cumulative exposure. So if you take a person who has a high LDL cholesterol and is 60 or 70, inevitably will be in the area of red, alarm, but because it's been exposed there. And the younger fellow will not, because it will be there and is younger. That's a different way of looking at it. And then if you look at the high-risk region, low-risk region, and you look for the score 2 and the score 2 older patient, all patients are all red by definition. So that means all of them needs to be treated aggressively. That's fine, because we reduce cardiovascular event, but tends to forget the other ones that will come there and doesn't cover for the damage. And the absolute benefit you will get there will be less. Please remember, there are some suggested data from prevention studies in primary prevention indicating to the same level of LDL reduction as time goes longer, you can get even larger benefit when you start earlier. But that's something that needs to be checked. This is a way to cope with this storage, to decrease the level of threshold for being at high risk or very high risk. But that's just a mathematical approach. How can we put things together? Some people is suggesting to use the imaging as a way to identify people who are more susceptible to cardiovascular disease. So looking into the possibility of having the presence of subclinical atherosclerosis. And this is one way of doing that. It certainly will be the possibility, but you cannot put everybody into analysis of cardiovascular over-the-air arteries. Other ways are these ones. That is how to look at some markers that you can find in circulation, possibly few markers that go over and above the LDL cholesterol and other classical markers we have. It's possible, yes. Has been demonstrated in selected population, yes. There are the scores you have seen for genetics. There are scores for proteins as well. And this is a way, perhaps, in which you can start thinking of, in your population, checking for the people for these biomarkers, and those who qualify for a high level of those biomarkers eventually put a flag on them, following them more frequently for the presence of atherosclerosis. But we have to do it earlier, not at late stages. And this is an example of what we saw by doing this approach. We took people with FH, and there is a biomarker that overperforms everything, FGF5. This biomarker apparently makes a clear selection between people who has FH and people who do not have FH, independent of LDL cholesterol, by the way. So that tells you something that makes you the cumulative exposure, probably, and that's what we are looking for. And this is the data that we have shown. And this is the concept that I was making, the capability of selecting these patients, but not discriminating in basis of the LDL cholesterol between non-FH and FH. It just picks up the concept you are FH, not because you have the same cholesterol. And the obvious explanation is that the exposure has been completely different in those subjects because FH have had a lifelong exposure to high LDL. Again, the use of these proteomics may also help us to understand what is happening in our subjects. These two graphs shows you the effect of PCSK9 inhibition. In this case, is the use of, if I recall correctly, alirocumab, and in the other case, the use of colchicine. And this is a selected pattern of proteins. The only protein that changed significantly in PCSK inhibition in circulation was PCSK9, which dropped a lot. With colchicine, you can see there the number of proteins that were affected, all of them going to different pathways, indicating the complexity of this action. Finally, imaging. So if you do, let's finish with proteomics. This is another example where a 27 protein model identifies people at low risk of developing the disease up there to the high risk of developing the disease. And that these are just the years after the prediction. You see how well they can differentiate between those subjects. So that means, again, we can perhaps, through proteomics, be able to detect that. Why I say proteomics? Because proteomics is the endpoint result of all the system of genetics, epigenetics, and environment. Genetics can tell you things, but they can be modulated by epigenetics, can be modulated in their expression by a number of things we do not know yet. Proteins are made by the results, as a result of what are the genetics that are behind that. And finally, the final suggestion that we had is we can integrate those things. Genetics are important. Genetic predisposition may inform you about the status of that patient or subject. Plasma biomarkers may help you to refine that suspect and perhaps having an idea of what has been the exposure to the risk factors that we are talking about, the main causal risk factors. And finally, certifying by imaging may help you to pinpoint, to put a flag on those patients who need hard intervention, very intensive, and attention that has to be repeated very frequently over the years. So in conclusion, cardiovascular risk estimation had become rather static and needs to be completely changed. Otherwise, we will keep treating elderly people and forgetting about the people who may give us the best result in terms of preventing events. Second, we are entering an era of exciting new concept and collaboration, including the concept of cumulative exposure, which we need to further refine. Then moving from the 10-year risk to an exposure time model and to early treatment has the potential to become a standard, especially in patients who are at risk. Let me conclude with this slide that this is a sentence that I found in the literature, in a book from Chinese medicine, 2600 before Jesus Christ. It's not my translation, so I don't take responsibilities, but that's what came out from the translation. This is not even Mandarin. I don't know what language was. Nevertheless, what says, in essence, that the best doctors prevent the disease. Average doctors treat the disease before it's fully evident. Doctors that need to improve, let's put it this way, are the ones that treat the full-blown disease. I'm afraid since 2600 before Christ, we have not changed much. We still are towards the bottom of that sentence. Please remember, physicians in China, if they were wrong, they lose their head. So that's what probably was behind that. Thank you very much for your attention.
Grazie tante per la bellissima presentazione. El doctor Catapano ha tenido además la generosidad, en contra de lo que es habitual en las charlas magistrales, de ofrecer un tiempo para que podamos discutir. Antes de que alguien levante la mano, quiero aprovechar también para agradecer que bajo los auspicios de Fernando Cibeira, del doctor Catapano y de Rosa Sánchez estamos estableciendo mecanismos de colaboración para que los registros de hipercolesterolemia familiar de España e Italia trabajen en conjunto para poder ofrecer mejores soluciones que tenemos quizá demasiado dominadas por los, digamos así, los bárbaros del norte, ¿no? Los que nos han enseñado las clínicas holandesas, etcétera, pero necesitamos tener datos propios y creo que la conjunción de Italia y España nos puede dar pie a tener mucha más información importante. ¿Alguien se anima? Si no se anima, yo le hago una pregunta. Reconocemos la aportación de las guías que ha liderado Alberico, el colesterol cuanto más bajo mejor. cuanto más intensamente lo bajemos también. Y recientemente, en las últimos lipid update, cuanto antes mejor, no nos retrasemos. Pero quería hacerle la pregunta en los jóvenes. ¿El riesgo relativo es más bajo con estatinas en sujetos de 20 años que en los de 40? ¿Qué debemos hacer para pacientes jóvenes que tengan dislipemia sin llegar a HF, pero que ya anticipamos que el riesgo vascular a lo largo de la vida va a ser elevado? I get you was the question, right? Okay, I'll say it again, just in case. For younger people who do not reach the diagnosis of familial hypercholesterolemia, but we may anticipate there is high risk, using our current guidelines, suggest do not to treat because the risk is relatively low. What would you do?
Well, yeah, I think, I mean, if you take the examples of FH, I think they have exceedingly high LDL and should go low, even when they're young. So the therapy should be high. In terms of people who have not FH and have an LDL that requires attention, I think it's a matter of deciding how you want to attack that point. Because what the cumulative exposure is telling us is what we know for preventive medicine. You can move a population in terms of events from here to there, actually, just by decreasing not too much the values of blood pressure, few millimeters of mercury, of glycemia, and or of LDL cholesterol. That has been shown. North Karelia study is a very good example. For those of you who don't remember, North Karelia is the part of Finland at the border with Sweden and Norway and Russia, where the borders are not borders. The people who live there, the Sumi people, and they do not even know which nation they belong to, but nevertheless, they had cheese and milk. That was their food. Now, they changed over the years their attitude towards food. They went to a less fat-rich diet, let's put it this way, and the rate of event in that part of North Karelia decreased dramatically, 50%, more than 50%. Then nowadays has changed a bit back, going back to the usual fat-rich food for several reasons, and you can see again the rate of events going up. So you can show that at the level of population. Our problem is a different problem as a physicians. Our problem is we have in front of us one person, yet we try to apply things that are becoming from population evidence. All the stuff we have for trials, from evidence of risk, is coming from population because we see the averages. Even in the trials, we see the averages. We don't see individual patients because that will not count for statistics. But what we see in front of us is one person. And what is the challenge is to understand how much cholesterol, blood pressure, and obesity will be conferring risk to that patient, or how much will be the benefit for an intervention. And this is the risk that perhaps by starting recapitulating exposure will help us to narrow down this population, this prediction, and even going more personal in terms of proteomics, and then imaging will allow. And then you decide what kind of intervention to do. Before that, you will work with average in one person that may not well represent the average, which we know occurs very often.
Any question for the audience? Well, then, would you use any other instrument as relative risk, vascular age, or any other usual measure to stimulate people for increasing therapy for younger people?
Yep. I think there are very promising things that are occurring out there. And we have discussed also that for familial hypercholesterolemia in our discussion. In my view, there are three things that are promising. All of them are largely experimental now, but needs to be proved, but they are important. One is the telomere length. The length of the telomeres, which are portion of the chromosomes at the end of the chromosome that control the chromosome stability, narrows down with age. But in presence of smoking, high cholesterol, they decrease, become shorter. So this is one way to select early aging. The second one is linked to epigenetic clocks. There are what is named epigenetic clock are the identification of methylation and other changes in DNA that are linked to early aging, vascular aging, for instance. And there are scores for that. And that's also something that is very promising. And the third, that in my view probably is the best at the moment, is the clonal hematopoiesis of uncertain significance, which is a condition whereby you get clones of cells that are from the bone marrow that pile up in your blood. And this is typical of aging. All of us, we have that, and is linked to cancer after 60, 65 years of age. However, it's also linked at early ages when occurs to cardiovascular risk and early cardiovascular risk. So these three approaches might help with something that doesn't require CCTA and things like that, at least to stratify earlier.
Muchas gracias. Aprovecho para recordar que mañana en la conferencia de clausura, precisamente María Blasco, una de las más expertas en España respecto a los telómeros como marcador de longevidad, y para que la gente que no se despiste a última hora que pueda asistir a esa conferencia. Y si no hay más, yo creo que ya hemos casi abusado del tiempo que nos ha dedicado Alberico. Grazie tante, ahora. Muchas gracias de nuevo y gracias.